But to kick us off and start this session and open it up for us is none other than the Africa Director at the Gates Foundation, Dr. Paulin Basinga. He leads the Gates Foundation's work across Africa, bringing senior leadership experience, spanning advocacy, country programs, and health systems. He previously served as the Global Director of Program Advocacy and Communications and Director of Health for Africa, including a tenure as Country Director in Nigeria. A physician and a public health expert, he has held roles across HIV, primary health care, and health sector reform with early academic leadership in Rwanda and advanced degrees from Tulane University. Ladies and gentlemen, with a massive, welcoming round of applause, help me welcome to the stage Dr. Paulin Basinga. A bit louder at the back. There we go.
Thank you very much, Karangania. Everything you said, there is one thing missing in my bio. It's AI or digital health expertise, so I don't have. So this is why I'm so stressed. I need to make sure that my remarks are well here so that I can actually read through. So I came earlier today and I was sitting in the back of the room to just feel and understand what is happening in the room. And I was hoping that I will be able to acclimate myself into this amazing room full of experts. And then I sat in a very wrong place. I don't know if the gentleman sitting in the back is there. There is someone in the back actually running some set of analysis in their computer right now as they are listening. So remember when you're in graduate school, you run your Stata command and you go to get a cup of coffee. If you came back and there was no mistake, it would just run through and you have the output, right? But if there was a mistake, you are in trouble. And you have to redo back, etc. So this is the room. I think it's a representation of the people who are in this room today. But I'm here to represent the Gates Foundation, and we are so privileged to be associated with this amazing conference and to share with you where we are in our AI journey and how we're thinking about it, and also the conversation we're having with our partners, other funders and grantees and government officials, etc. So when I think about AI, it just brings me back to sometime I visited a facility outside of Kigali. And a nurse there showed me a very simple mobile app to track pregnancy and send reminder to women. Because as you know, pregnancy is not a disease. Many women, when they come to facilities, they want actually to know what will happen with them. So that nurse had this very simple app that will know exactly which women came, how many ANC, when do they need to come back, etc. So she can send a reminder to those women to come back so that we can detect the 15% that may be at risk and then really make sure that that risk doesn't happen. But now, that was a magic tool that worked and continued to work. But now imagine what that same nurse can actually do with the kind of AI tools that we have now. The AI tool that can speak her language, that can respect her reality, and then also if that AI tool is actually tested in her setting so that she can actually use it effectively. So this is why evaluation in the era of AI is so critical, and this is why making sure that the innovation that we are all using here actually serve people, not the way around, just creating a lot of complexities, etc. As you know, artificial intelligence is no longer a distant promise. It's here. It's happening already. People are using different sort of artificial intelligence. But we need to make sure that from algorithms that are predicting outbreak malaria here in Kenya or to chatbots that are supporting maternal health in Ghana, Africa is actually really at the center of developing those tools, and they can actually decide in terms of what it will do in the future. But we also need to be very honest. When you track information about AI today, it's very clear that the benefits are not equally shared. Over 70% of all AI investments are not happening in Africa. They're happening in richer countries, while many health systems in the global south continue to face data gap, limited infrastructure, and weak governance. I heard from the earlier panel today that Africa CDC is actually leading in terms of really creating AI governance tools that we'll all use. And Smart Africa just launched now an AI council that we are very privileged to be part of, so we can actually, help and contribute as African to actually shape the policies across the continent. That's why at the Gates Foundation, we've started very early on. We saw the potential of AI in transforming the work that we support. We support health, agriculture, education, etc. And I think 2 years ago, a little bit more than 2 years ago, we supported AI solutions with a 30 million investment across Africa. Some of our partners are in this room that have been able to actually go in the field and test some solutions, and we're seeing some really concrete results. And then from those pilot solutions, we've also been able to work with a number of countries, including Nigeria, Rwanda, Senegal, and potentially down here in Kenya, to establish those AI scaling hubs so that the government can be in the central to actually plan for the scale up those, so that collectively as a field, we need to avoid one thing. We need to avoid the mistake we collectively did during the digital health era, where there were just multiple pilot programs that went nowhere. There are few of them that actually, were able to be scaled. But during AI, it's even easier now to create. Sometime as a funder, I get requests from some of our grantees. I can very much see the concept note was generated from a ChatGPT. I'm like, do some effort to put some thinking, right? So we will see a lot of pilot programs, someone just thinking that they can resolve something without really thoughtful understanding. So this is why evaluation is so critical. Evidence tells us what works, why it works, and for whom, but most importantly, at what cost. It shows whether AI tool is improving clinical decision or creating bias, whether it's helping smallholder farmers protect the harvest or giving unreliable advice, or whether it's supporting a teacher in a classroom, or maybe widening learning gaps. Across all those sectors, there are some questions that we at the Gates Foundation will be consistently asking ourselves as we engage in AI. 6 questions. Number 1 is really, can we try to see what is the practical use case, not the theory, but really the real task that AI meant to improve? Is it reducing a nurse workload? Is it diagnosing crops disease? Or is it identifying learning gap? The second set of questions will be, what is the specific problem we're trying to solve? Is AI, going to really solve a bottleneck? Or if you really think through, it's going to actually create those one. The third one is some of the basic preconditions that need to exist before you even launch AI. Is the data that you're going to use trustworthy? Is the infrastructure stable? Are the governance and privacy safeguarded in place? I think one person in the earlier panel, really, I didn't got his name, but he said something critical, that AI need to actually be elevated at the head of state level. If you don't get it there, because there are just too many ministries that are impacted to really make sure that AI does. So do the institution and people have the capacity to use and sustain that solution? And then also, more importantly, who will actually pay to keep those foundations in place? So if we don't think about that at the beginning, it's very difficult. Those are the questions that our panel list will be discussing. Fourth, what are the risks that we need to think about? Could the excitement around AI distract government and partner to actually fixing the basics? Sometimes we don't need an AI tool. We just need to show up at work and to fix. Sometimes paperwork just works fine. But sometimes we can over-engineer things because there is this new AI things. And then fifth is actually the AI tool going to save money. It's going to reduce time, reduce cost, and improve outcome. As we all know, global health development and health is having a massive crisis. ODA is going to be cut in a very significant way, 30 to 40% going forward. So anything that we do need to actually cut cost of delivering program down. If not, it will not work. So, and then finally, where has this solution worked before? If it's new, can you couple this with a very small evaluation to have a go, no-go decision as you move forward, etc. So this is why this panel is so important, that independent country-led evaluation led by local partners in countries is so critical. Now, across the continent, as you know, this evidence-based approach is already shaping how we build and scale innovation through the Africa AI Transformation Framework that has been developed. We will be helping to turn promising idea into national system of impact. And then also the AI scaling hub that I mentioned. And we've now started to really see very concrete example. Like in Rwanda, where an AI powerful ultrasound tool supporting maternal health and AI-driven supply chain intelligence is helping improving Rwanda medical supplies. In Nigeria, predictive analytics are strengthening maternal and newborn health services. Senegal, AI-powered agriculture advisory tool and digital education platform is a reality. And here in Kenya, we are working to integrate AI into health and agriculture system from the start. But these hubs and ways of working are not like research projects. They are implementation engine. They're putting government in the center, from the Ministry of ICT, Ministry of Health, Education, Agriculture, and also helping to really contextualize AI in a very, in a way that it can actually work on the continent. But now, we must also at the same time confront the risks. There are algorithm-based, biases, there are data privacy, opaque decision-making, but we can manage this risk responsibly if we really keep people in the center. Technologies will make life easier for a nurse in rural Sokoto, or the community health worker in Kisumu, or a midwife in Accra, but not really complicating their lives. We just need to make sure that we're not pulling them from their posts to bringing them to places where we're going to retrain them, etc. We need to find them where they are and make their life easier. This is why over the next 2 decades, the Gate Foundation has decided to close its door by 2045. And you've heard from Bill and our CEO, Max Suzman, our board, that we're going to really focus on 3 very concrete goals: reducing maternal mortality and FAV mortality, reducing infectious diseases, and then lifting as many people out of poverty, especially through agriculture, digital public infrastructure, etc. And we fundamentally believe that AI will have a critical role to play to make progress faster, better, so that we can actually improve, as we close, improve the life of people, but also leave Africa in a place where AI and digital health is an asset and not a liability. But now, I'm going to invite my colleague Melissa Miles to come up and invite her panelists so that you can hear from the Gate Foundation. Melissa is from our primary healthcare innovation team, and she also supports most of our AI work across Rwanda, here, and other places. So Melissa, come on, and you can send all the tough questions to her. Thank you very much.
Thanks so much, Pauline. Thank you, Pauline. Those were amazing remarks, and I think you've framed up the opportunity, but some of the potential challenges and risks ahead of us as well. It is a pleasure to have the opportunity here today to help frame this discussion. This is a space in which I know that there's a lot of excitement and expectation, but also a fair amount of caution, fairly, being exercised to ensure that we can really, truly unlock the potential of AI, as Pauline has shared, and generative AI, in particular, in under-resourced settings. So on this panel today, we'll be talking about how we strengthen the evaluation approach and the evidence base for what works in AI in global health. With that, I'd like to invite my esteemed panelists on stage. And as we're all getting, do we have seats? Okay. As we're all getting seated up here, and before I hand over for introductions, maybe I'll just open with some framing for this session. So first is that I hope we can leave with clarity on what we mean by evaluation. Because evaluation must tell us not just whether the AI model works, but whether the overall intervention itself drives measurable change in people's lives. A framework that I've found really helpful is the 4-level CGD and agency fund one, which Tamina will speak to. Second, I hope we leave with why are evaluations of AI critical. They help us understand whether and how these tools in real-world settings work, whether they're justified in an environment of declining resources. Every dollar spent here is a cost and an opportunity from somewhere else. And as we know, conditions in many LMIC settings are not the same as where AI models and tools are developed. And that means that we need to ensure that we evaluate models on context-appropriate, representative, and real-world data. And finally, as we know, the nature of Gen AI is different. It's inherently not stable. The models evolve. There can be hallucinations. And so this creates a need for continuous evaluation in order to responsibly develop safe and successful Gen AI products. Finally, I hope we'll leave this panel with a sense of how to do this well, with some examples too. I think that this requires a little bit of a mindset shift for us in the global development space. We're used to very formalized, structured, baseline, midline, endline structures. But AI evaluation has to look really different. There has to be rapid cycles, continuous monitoring, and it needs to move from episodic research to really being part of a continuous product stewardship. And I think I'll add in there also how we can think about the role of AI itself in assisting with some of the monitoring and evaluation, because we know that this can actually be a very costly part of the implementation. So with that framing, I'm going to hand over to the panelists here today to introduce themselves. They're bringing perspectives from multiple vantage points. Maybe we'll start here and go down just with quick introductions.
Wonderful. Thank you so much, Melissa, and it's a real pleasure to be with you all today. I'm Nneka Mobison. I'm co-founder and CEO of MDoc. MDoc is a digital health social enterprise which provides AI-enabled virtual health coaching to people living with or at risk for chronic health needs. We're headquartered in Nigeria. We serve over 162,000 people. And just in terms of my background, I'm a pediatrician with a background in quality improvement, which I think has a direct impact on how we've approached evaluation at MDoc, which we'll share shortly.
Thank you, and thank you so much for your attention and for participating in this panel. My name is Tamina Martin. I'm a co-founder of the Agency Fund. We're a donor collaborative that tries to expand human agency through grant making to organizations that coach, counsel, mentor, and support people in their health journeys, in their livelihoods, and in their education.
Thank you. Good morning, everyone. My name is Karthik Kadapa. I'm the Regional Advisor for Digital Health at the World Health Organization. In this position, I lead Digital Health and AI in the Southeast Asia Regional Office. As WHO, we set the standards both in terms of the ethical as well as governance for AI, globally and regionally. We kind of take this normative guidance and build strategies for governments. For instance, for India in the Southeast Asia, is going to be the first global South country to have a national AI strategy for health. This is the kind of work that we do at WHO, where we help build the foundations both in terms of digital health and AI, and support countries in their digital transformation. I'm a physician by training, an internal medicine physician, an academic at the Yale School of Medicine and at University of North Carolina. That's where I do my research. But I also work for the Government of India as an Indian Administrative Service Officer. That's where I do implementation work. But currently, in my current role at WHO, I play more role in terms of building policies and strategies for government.
Thanks so much. So for the first question of the panel, I'd love to come to you, Nneka. I think we can all sit in this room and talk very abstract sometimes from the forums I've been in. But I'd love for you to speak as an innovator. How have you actually gone about the evaluation process and evidence generation? And what have you found meaningful in that?
Thanks so much, Melissa. So I think it's really important to just situate MDoc as a for-profit social enterprise. We've been doing this work since 2016. We literally set this organization up on the belief, actually on the evidence that existed, that self-care could be leveraged to help people restore their agency, to build their confidence in helping them to manage their health on a day-to-day basis. And we were seeing what was happening around the world in terms of, especially in Africa, around the growth in NCDs and, quite frankly, the lack of investment towards supporting that. And so that's what we started back then. And early, we realized that we had to have an ecosystem approach. And so the MDoc that we essentially built and co-designed with the people that we served is essentially a hybrid platform where we provide this virtual coaching with human coaches, but now AI coach called KEM, as well as in-person, a phygital approach where we have community-based nudge hubs where people can actually access care. We extend care into the community. And that's buttressed through a Navi Health, which is a Google Maps for healthcare, we like to say, a directory of healthcare services for referral, and then finally a teleeducation platform that really bolsters capability and capacity. I'm highlighting those 4 points because we've had to, over the last 8 years, try to create a connected ecosystem. And so over the course of that time frame, when we started leveraging AI, which was in 2020 when COVID hit, we recognized that we could leverage our kind of learning system that we had built to start observing and to really test what we were learning from AI back then. Initially, we built Chem as a coach chatbot, a rule-based chatbot, very simply to help people with hypertension. And then when LLMs essentially were made public, we started continuously learning and evaluating and really leveraging this rapid cycle user testing framework that we had built. To Melissa's point around rapid cycle testing, because I come from a quality improvement background, we had learned back then that micro-experimentation could really drive the needle when it came to really proving quickly from an implementation perspective that you could generate change when it came to behavior and as well as health outcomes. And so over the course of the last few years, we've kind of looked at evaluation from 6 particular domains. And we've had to build internally an evaluation framework and an evaluation system that works. And we've had to do this, honestly, because the more we did, the more we were trying to validate externally. And people were like, oh, good to hear you're doing that, because we're trying to validate with you. And we're like, wait, this is not how it's supposed to work. Historically, we've always looked outside. But for what we're trying to build internally, we had to build this kind of 6-level system. First is really looking at the model, right? So is Chem, our health coach chatbot, sitting in our broader 4-point platform? Is it really effective? Is it doing what it's supposed to do? Is it accurate? Is it safe, right? And then the second piece is risk mitigation and identification. Early on, we were able to see that Chem wasn't doing great at identifying risk, right? We were literally having people overnight really trusting Chem in ways that we hadn't seen that trust with human coaches. Literally, we were seeing suicidal ideation, people talking about sexual harassment, people talking about abortion. And we hadn't seen that to that level in our human coaches. And so we had to really build a system where we could ensure that Chem was identifying serious and urgent cases, and we had a system to deal with that. The third bit was really around CAB, what we call CAB, which is knowledge, attitudes, and behaviors. So were we really seeing a change in health literacy? Were we seeing a change in self-efficacy and the confidence? Were we seeing trust to leverage Chem? And we could see that conversations evolve. So where they might first just ask a general question, over time they're really trusting Chem more and more and really confiding in Chem in ways they're not doing with human coaches. The fourth is really, really critical, which is ecosystem evaluation. Chem is not sitting by itself. Chem is sitting in this broader ecosystem. When a woman is saying to Chem, I'm having contractions, or I'm having something, my abdomen is paining me, and Chem is answering, is Chem supposed to refer to that woman to a health coach, or in that moment, should Chem be referring that woman to a healthcare facility and then following up right after? Right? And so then are we now linking to the healthcare facility and ensuring that they're providing the kind of support that that woman needs? And so we've now really had to look at what are the interoperable systems, how are we linking with government, what does it look like end to end? The fifth piece is ecosystem, it's workforce readiness. I think Paula talked about really the AI capability and literacy has to sit with the heads of state. I cannot highlight that enough. In my own organization that's been leveraging AI for 5 years, I will tell you not everybody understands AI at the same level, right? And in this room, I'm sure not everybody does either. And I don't think it's an excuse anymore. You need to invest, you need to learn, right? Because we need you there to be able to say, no, this is wrong, or we need to be asking these types of questions. And so we really had to look at, is our health workforce internally, workforce outside, are our and really build and invest in the ways that we need to from an evaluation perspective. And then the fifth, obviously, is impact. Impact looks not just at, are we seeing an improvement in health outcomes, but what does this mean for sustainability? What does this mean for cost? Is MDOC going to be able to be here in 5 to 10 years now that we're seeing, quite frankly, our liability has gone up, right? Because now that so many people are trusting in Chem in ways that we weren't seeing before, what does that mean in terms of what we owe to the member? Do we owe them the right to ensure that they receive that end care? If somebody is suicidal, what's our responsibility in ensuring that person gets emergency care when ambulances don't exist, when there are not services for mental health that we need in the way that that person deserves. So it's all those elements together that have required us to really build an internal evaluation system as well as an external evaluation platform to really ensure that we are doing what we can to serve people in the best possible manner so that we can transform health outcomes for the better across this continent without ever causing harm.
Thank you. That was excellent. I think you've highlighted really well how evaluation for you, it wasn't just about, providing an endpoint or endline evaluation. It was fundamental to how you developed the tool, the product, how you understand if you're driving towards change.
We I think, again, coming from that science, quality improvement background, we took, and also from digital, we took out wireframes in the early days and tested with our population. We didn't wait to build a product and then test. We co-designed with the people that we serve. When we took Chem to the markets, and we're like telling women, okay, write in Yoruba to Chem. And then they're telling us, but I don't know how to write Yoruba. I can't speak Yoruba. And just by that, we're like, wait, okay, we need to urgently add voice, right? We need to think about language in a very different way. And so it's when you co-design and build that rapid cycle user testing framework into your evaluation system, I think you're able to really accelerate being able to truly solve the problems with the people and for the people.
Mm-hmm. Mm-hmm. Maybe with that, Tamina, I could come over to you next to talk about NECA had highlighted really well how they, as an organization, are approaching evaluation. The agency fund has developed a conceptual framework for organizations to use, and you've implemented that and learned alongside organizations as well. Can you talk about what that framework is, and then also where you've seen the importance and maybe challenges and how different organizations can adopt a cohesive framework that we as an ecosystem can learn from?
Sure, thank you. In early 2025, we launched an accelerator with 8 nonprofit organizations that are all early adopters of AI. And I'll share a little bit of their stories, but this was joined with the Center for Global Development, a think tank based in Washington, DC and London, and with OpenAI, the foundation model company. And our interest in launching this was to provide funding to organizations that are bringing AI to scale alongside government. All of these organizations support governments in the delivery of services by injecting innovations. And as a result of implementing and learning alongside this set of organizations, we saw some patterns emerging. And these sort of catalyzed the development of this framework. The framework has 4 stages, and we think of them as motors that you switch on as you're developing a product. So these are, first of all, does the model or the models that you're using for your product, your AI product, are they performing as expected? These could be language models used in a chatbot like Chem. They could be computer vision models that are used to diagnose diseases using imagery. But we want to understand when, where, and how these models behave and use model evaluation continuously to flag problems with the models and try to introduce guardrails. The second motor we switch on, once we've deployed a product with models that are now being observed, is product analytics. Are the products that we're delivering, putting into the hands of people, actually being used? What is the rate of user adoption? What is the rate of user retention? Are we getting meaningful engagement? If we're not getting meaningful engagement, we often don't expect health outcomes to result. The third motor we switch on, and I think NECA mentioned this, is understanding users' behaviors, their beliefs, their moods or affective states. How are they being changed through these conversations they're having with the language model or through interaction with the digital app? And there we're interested in measuring things like agency, self-efficacy. Do people feel that they're in control and getting resources that they need to drive health outcomes? Or are they cognitively offloading? Are they unable to use the product meaningfully? We need to understand what their behaviors and beliefs are coming out of the engagement. And then the fourth motor we switch on is impact evaluation. Can we understand, once we've deployed a product, people are using it, we're confident in its reliability, and we understand how users are changing as a result. are those users able to produce health outcomes for themselves by interacting with the health system? So again, very similar to what Neka had said. And in observing how these NGOs that we've operated with have implemented, we've noticed a couple of things. One is that often global health organizations are at the forefront of the science of whether or not these models work. They're doing model performance evaluations. They're sometimes fine-tuning models that Meta or OpenAI or Anthropic are offering for local language. And they're discovering that some of the metrics that are used by foundation model companies are not appropriate. We want not a word error rate for a Swahili language model. Perhaps we want something around meaning preservation. It's a very different set of metrics that you'll use. And it's Global South organizations that are exposing this because they're testing in context in the real world settings in which they operate. So that was one example from Jacaranda Health and their work to develop a Swahili language model that would work in the context of maternal and child health. We also saw AI can be a powerful tool for personalization. And through rapid A/B testing again and again of a chatbot that Noura Health in India developed, they were able to show how personalization in various means and mechanisms of the chatbot could increase user engagement. That's that second motor that we switch on. How do we improve over time our user engagement so that we get meaningful levels of interaction with the chatbot? Not a one-time question asking, but a routine return to the product to answer questions that people need to improve their own health. We similarly have looked at some of the question-answer conversations and started to analyze to what extent the bot is driving the person versus the person using the bot to improve their own agency or to engage in a kind of collective agency. And finally, we've seen how these organizations react to impact evaluation. As has been said on this panel, AI product development requires continuous A/B testing, continuous evaluation and tweaking, lots of knobs that you can change. And that doesn't work well for a clinical trial. A clinical trial, or even an implementation trial, expects you to freeze your intervention and roll it out to a randomized treatment group, compare with a control group, and in several months from now, we get an answer about whether the tool worked. That doesn't really work, and we saw Reach Digital Health have an experience in which the South African government was interested in the maternal and child health Mom Connect product that they had. They were bringing in AI, but a very rigid clinical trial doesn't work well for a product that needs to continuously iterate. And so I think that our government institutions will need to shift as we see this framework being adopted. Melissa, you asked why it might be useful for frameworks to be adopted broadly. I think it's really so that we can learn from each other. There are so many disciplines and people involved in the production of AI products. There are computer scientists, obviously, data scientists, there are user researchers, there are health improvement researchers, there are economists, there are clinicians, and we really need to build a common language and a common set of tools so that we can learn from each other and move forward as a field. Thank you.
Thanks so much. I think you highlighted really well a starting framework that we can all use and build upon, and as you say, in order to learn from each other, and so organizations don't have to repeat the same lessons and same tests every time. Karthik, I wonder if we can come over to you, and as you think from the WHO perspective and the normative guidance that you all put out that are helping countries understand, is this an effective intervention? Should I uptake this or another one? Those are real trade-offs that ministries of health and governments are making. Can you talk about what are some of the unique set of opportunities in the AI space, how you're supporting ministries of health, governments to think about that, and also if you could talk to some of the risks or challenges that you see?
Thank you, Melissa. I think it's been very helpful that a lot of context has been placed. So from an LMIC perspective, let me talk about just 4 broad principles. First is, we've talked about local validation. Let me call this more contextually aware validation. So it's going to be very important that most LMIC countries now, essentially in Southeast Asia, very often we hear a lot of models, algorithms that have been built in higher income countries being exported to the LMIC countries. And so therefore, it becomes extremely important that the point of contextually aware validation or a local validation. The second thing is what Tamina talked about, which is a little bit about continuous evaluation, which I just wanted to talk a little bit about what algorithmic drift and shift happens, and therefore it is extremely important that we do a long-term continuous evaluation, and therefore this traditional clinical implementation research, clinical trials are not really helpful there. The third principle is the importance of a holistic evaluation. I think gone are those days where we could just focus just on a one set of approach or a discipline. We now need ethicists, statisticians, computer scientists, public health researchers, evaluation experts, a bunch of interdisciplinary research that is needed for a more holistic evaluation rather than a very specific one. And that brings me to this very important point of where we do evaluations that are not based on model orientation but on outcome orientation. So no longer should evaluations be just based on outcomes, but more essentially on these static benchmarks that we've had, I don't think are really going to work. So even in the way AI ML has evolved, the traditional machine learning methods, even in large language models, and now even in the large language models, most of the evaluation frameworks are more towards unimodal data and not really multimodal models. So as traditional machine learning, Gen AI, and within Gen AI, as we get multimodal models, none of these traditional static benchmarks are going to really work. And so therefore, what is going to be very key for funders, donors, governments, ministries, and more specifically for normative agencies like WHO is to think about how do we ensure that we evaluate these multimodal models, which is essentially going to be where most of the AI is going to move around, right? So those traditional two-dimensional imaging, computer vision models are going to clearly give way to these multimodal models, and so therefore ensuring that they're just not continuous, they're holistic, they're contextually aware, and they're outcome oriented. I think here is an opportunity now for LMIC countries to ensure that AI evaluation is not optional but mandatory, and it is essentially very pivotal that everything that we do in healthcare about. So it is not about AI in health, health AI. The focus therefore has to be on improving health outcomes and not really improving the performance metrics that we've all been stuck with in the AI world. So I think as AI developers think about performance metrics, it becomes very important for public health researchers. And I can certainly see some of them clapping to this because I am an extremely enthusiastic AI developer, but I'm a public health scientist at the core. So for me, what really matters is not evaluation that are targeted at performance metrics, but more on health outcomes. So, and that is where I think more of the normative guidance would come into. Thank you.
It's really helpful. It's so important, as you say, to focus on what's the outcome that we want to see, what's the change in the world that we're trying to drive towards. And we see AI can be an amplifier, right? It can be an accelerant to help us achieve those goals, but to stay laser focused. Maybe I'll do a round robin question now, because I think on the flip side of that, AI presents some really unique challenges, right? There's, on the one hand, it's never been more opportunistic to scale something. You don't need to go in the old days of digital health and individually tailor to every single protocol a specific tool or platform. You can design things that are inherently more scalable. On the flip side of that, there's the challenge that LLMs are, when we talk about generative AI, inherently non-deterministic. And how easy is it to explain to your average health worker or your average client that this is a probabilistic output of what we might be telling you based on the data patterns that we've seen in our training data? It's not always an actionable answer for them. As well as the models aren't static, right? Which I think a lot of you spoke to. The frontier AI labs are continuing to evolve and to work on models in the background, and points to the criticality of evaluation like we're talking about. But with these qualities of generative AI, can each of you talk to how you've thought about building trust, building confidence, even within your own teams, but then within the ecosystem that you work with, on how do we rely on these sorts of AI models? Maybe I'll start with Nekya and then we go down.
Thank you. So we have trust is core to us, right? Again, just having done this for so many years, we've been able to look at our data and see, when we have, for instance, when we enrolled people, for instance, at a healthcare facility, and then within 48 hours ensured that they had their first synchronous interaction with a human coach, that had a massive impact on their long-term engagement, on their behavior change, and on their health outcomes. And so that completely changed what we did in terms of what we call establishment of care, that first interaction with a human coach. And so we've kind of taken that learning and tried to really work at building a system that facilitates that trust. But it starts with transparency, right? We are extremely open, I think almost to a fault of what the problems are in our system. And we see many gaps on a daily basis. And I think it's really important to be that transparent, whether it's with our members that we serve first, or with our funders, and truly with each other, because that's the only way we're going to get better. And I would say in the global health world, I don't think that is historically what people have really done, to be frank. And so it makes people uncomfortable how transparent we are with the reality and our challenges. But the second piece is really around, so just kind of setting that as a culture and an expectation. But the second goes back to investing in capability. This is what I keep on highlighting, because when you don't do that, so early on, when we started leveraging actually LLMs in particular, I just saw a divide in the organization between clinicians, our clinical and coaching team, and our ML team. Right? All of a sudden, the ML team, they were now the experts. They were like, and they felt it too. They was like, okay, finally, we got to stay here, right? Clinical team can't say anything. And then the clinical team just started kind of pulling back, right? Physicians that used to be, at the top now didn't have that confidence anymore because they didn't really understand data science and didn't understand ML. They were even confused about terminology. And then, quite frankly, we don't talk about gender, but there was a complete gender divide as well. And so we need to talk about the investments that need to be made to build that. When you build that knowledge, competency builds confidence. And so if we're going to be able to kind of foster trust, first we have to build a competent team that's able to pressure test, that's able to ask the questions, that's able to say, wait, why is Kem talking in pidgin right now and then going into English and then just going all over the place? Why is Kem, really kind of giving this advice when the ML team is like, oh wow, Kem is great, right? Kem is just like killing it. Kem is a fantastic triager. Kem is a wonderful coach. And why isn't the clinical team saying, actually, no, there are real problems here. Kem's tone is giving off to that woman that she's okay when actually she needs to be in a hospital right now, right? So it's that element of really kind of investing in capability and creating a learning system in your organization. We have Journal Club. We now have AI Journal Club. We have we review AI journal articles on Fridays so that we can keep up, in addition to our normal journal club that we have every 2 weeks, which is mandatory, right? We've built a system of everybody has to submit an abstract. Peer-reviewed articles, blogs, white papers, we've got to do it. We have to tell our stories. And so the more we tell our stories internally, the more we're able to be confident telling them externally, building that relationship with our governments, sharing together, learning together, and that truly will translate into improvement in terms of the health outcomes that we seek in the populations that we serve.
Thank you, Nneka. That was great. I would like to add maybe 2 or 3 things. The first is, when we think about AI product evaluations, we very much think about the data that we're using to benchmark the product's performance. And we often see nonprofit organizations or global health organizations choosing just clinicians as the arbiters of a model's performance. So we'll have a question-answer set of questions that patients commonly ask in a language model and what the ideal answer should be. And a clinician has gone through and rated the appropriateness of the responses. We use that to test the model. The reality is that patients need to be in that loop of human feedback. Community health workers need to be in that loop. There are so many cultural elements that are missing from a lot of these models that we need to build in, and we only realize it when we are collecting high-quality representative data from men and women to understand what's working for whom. And it is expensive to collect those data. You have to have some means, some harness to be eliciting feedback. But that needs to be built in from the beginning. So that is one thing, is who is providing your data for benchmarking? I think the second question is, what are the benchmarks we're using to evaluate AI products? And I like to think of it as a kind of a pyramid or a hierarchy. At the very top are these general benchmarks like word error rate or accuracy or precision that a lot of the model companies will tell you are important. But I think, to your point, you really need specific benchmarks when you have an AI product that's going out to a specific community. And so getting creative and I think a little bit more iterative in the model benchmarks or performance metrics we're choosing in those earlier stages of evaluation, the model evaluation, but also the product analytics and the user behavior. So I think the metrics matter, and we haven't figured out what the right ones are. And there's a lot of work being done by innovators in this room to help figure that out. The third thing I wanted to say is I would love to see every organization deploying an AI product put out a product card. Very simple form factor in which you disclose the model's performance, which models were used in your product, how they're performing, what safety guardrails you have, what your user engagement is, how you're seeing users' behavior change. And then, of course, some health impact at the end. Are you reducing readmissions to hospital? And I think that kind of transparency will build trust, because then we know what's in the product. It's like I come from biological sciences. It's like a material safety data sheet or some kind of sheet that gives us an understanding of what's in the product. I think that could help a lot in helping governments build confidence, maybe patients as well, if the form factor is accessible.
Thank you. That's so very helpful, Tamina. I would just add that in terms of the mindset, when we think about an AI machine learning product, is almost thinking about it like a pharmaceutical product, right? So typically like drugs, which have undergone huge pharmacokinetics, huge evaluation before they get into the therapeutic impact. So for AI machine learning products, can we think first about safety? Are they first safe for human beings? Just like how we think about a drug. And then are they efficacious? Are they effective? While it's much more complex than that, but is our mindset to first think about AI being safe and then being effective for what it has to be. So for that, the AI evaluation frameworks have undergone methodologically a lot of work over the past decade or so. We've spent a lot of time trying to think about these performance metrics in traditional machine learning. Now we're thinking about how do we think about new performance metrics for Gen AI. And we're now thinking about, within Gen AI, how do we think about unimodal versus multimodal? And that is where I think two broad thought processes have emerged. One is in terms of this continuous evaluation, holistic evaluation of machine learning models, where we use these automated evaluation methods, which will continue to be important. What is going to be important is the human in the loop. While you talked about community health workers, physicians, I would assume that as continuously as we evaluate the AI machine learning models over a long period of time, while these automated evaluation frameworks are helpful, it's extremely important that in terms of cost and time, is the human in the loop, how important is it to involve human and when do we use it? And how context specific are our metrics? I think understanding that every metric is not specific, it does not have to be generalized, they have to be specific to the use case, to the context, to the settings in which the AI machine learning model is being applied. I think that becomes even more important. And so therefore I wanted to kind of reiterate this importance of context-aware validations while ensuring that they're holistic and continuous, and then focusing more on outcome generation rather than just model metrics. So I think that's been my key takeaway as we've done a variety of evaluations, both in high-income countries as well as LMICs.
Thanks so much. So my hope is that we can leave this panel and this forum more broadly with not just enthusiasm for AI, but also some very concrete takeaways on how we generate the trustworthy evidence that we all need, that funders need, that policymakers need, that countries need in order to make informed decisions. I hope that we can agree on what good looks like, but also what good enough evidence looks like. And finally, that we all can commit as an ecosystem to a coordinated and harmonized evaluation approach so that we can, what we learn in one country, in one implementation, in one project, can serve the entire global health community. This is something that the Gates Foundation and the Agency Fund will be working on, building off of the Living AI evaluation playbook that you all have generated. And we invite innovators, practitioners, implementers to join us on this journey, to use that playbook, to contribute lessons learned. And that we can elevate very practical country-led examples that show what responsible AI looks like. That's all from our panelists today. Thank you all so much for joining, and excited to keep learning alongside.
Can we give them another round of applause? Thank you so much. Melissa, Neka, Tamina, and Karthik. Okay, I've just been asked to invite you all back to the stage for a photo. And maybe Dr. Paula, if you can join as well, just for a photo. Yeah. I can't see everybody's face, so if they are not smiling and you do not see teeth, please call out their names. Dr. Paula, everybody, let's ask him to smile. Dr. Paula, we need to see some teeth. Thank you very much. Thank you very much. Round of applause, round of applause. Thank you for the insights. We really, really, really do appreciate that. And I think we didn't get questions from the audience, but please feel free to interact. As they've mentioned, let's add to the playbook. Let's contribute. They are here today, tomorrow, hopefully the day after as well. Let's engage as when we find time.